I'm one of the palliative care physicians in Port Alberni. I've been doing palliative care for almost 10 years now. I'm trained originally as a family doctor, and I still do that. But palliative care was just something that caught my heart, to be honest. It's not for everybody. Not everyone, well, it is for everybody. Not everyone can find the joy in it, but there's a lot of joy in it as well. So some of the questions that are here, probably the first one is, what is palliative care? Palliative care is providing care for a patient and their family when they've been diagnosed with a life-limiting illness. So, you know, we often think of cancer, but heart failure, old age. We're living so much older than we used to. And I think we're starting to see, and you guys are seeing it every day, how medicine has come so far to keep people alive. And we miss the boat sometimes when it comes to really stopping and discussing quality of life and what we can realistically provide people. And palliative care often comes into play in those situations. So if someone I'm a big believer that if someone is diagnosed with a stage 4 cancer, and sometimes even earlier, if they are symptomatic from their disease, palliative care is a good team to have involved, because we hold the family and the patient together. So we're not just looking at one thing, we look at a person as a whole being, so their social, spiritual, emotional, their entire person, and we do the same for their family. So within palliative care, you often talk about symptom management, which is a big part of it, but there's also the social and the existential side of it, where you've probably seen patients that you're like just upping the pain management, and it is not touching their pain. It's because you're not treating their pain. There's something else going on. There's something, whether it is a trauma, a regret, things they haven't said, people they haven't seen, things they need to do, that is translating into physical pain. So sometimes there's no meds out there that are going to help someone's comfort. And so that's important to keep in mind. And we support the families and patient as they transition from a very active, hopefully very active life, to something that is more subdued and potentially has symptoms. And there's a lot of processing that comes with that. There is hospital palliative care, community palliative care, hospice palliative care. And then we also have MAID in Canada, so medical assistance in dying. Staunch palliative physicians, team members, there is a group that feels very strongly that MAID is not part of that. I am of the belief that end of life care is actually the umbrella, and so MAID 100% falls within that, and it's up to the patient whether or not that's something that aligns with their values. I very much believe I'm not here to judge. I am not here to tell anyone what to do. I give options and support them in that decision making. My patients laugh because I do warn them that I will be bossy if I have to be, if I think you're making a decision that's going to affect your quality of life. That's the only time I really get bossy with my patients. In the community and in hospitals, a little different here. So I do consults in the hospital. I'm not here every day because I'm not MRP, and because I'm the only one. There's no one else that I can pass off to every second day. I'm not here every day to see patients. I try to write out a plan of what I'm expecting and what I'm thinking I would like to see happen for this patient, and I'll often call and chat with the nurses and communicate with families while someone's in hospital as well. But I leave it up to the MRP to do the bulk of stuff. We also don't replace the family doctor. So I am managing symptoms and effects of the life-limiting illness, but if someone also has diabetes, I'm not going to renew your insulin and make all those adjustments. With how few patients have family doctors right now, I do end up playing a lot of that role anyways. But if someone has a family physician or nurse practitioner, we ask that they still stay very involved. And then in Port Alberni, we have Ty Watson House. I don't know if everyone has seen it or familiar with it, but it is a phenomenal 4-bed hospice that is community run, community fundraised. There's support from VHA, and it's honestly a magical little place. All the food is homemade. We always say we bring people in there to love them up, and we have had patients who stabilize and go back home. So we think of hospice as somewhere you go because you're dying. And the parameters are, if we think someone has 3 months to live or less, then they're a candidate for our local hospice. Some larger communities, I need to have an idea that they're going to be here a month or less. So we have a little bit more flexibility because we're a smaller community and have more control of our hospice, which is, to me, a wonderful thing. And there is nursing support there. I go in there a few times a week. Patients receive the 24-hour care that family may not be able to provide, but it's nice that it's not in the hospital setting. There's no bells and dinging and whistles and running and loudness. It is actually it's a heritage home. It's a historical home, so it's quite lovely. And it depends on community support. So volunteers, donations, we do fundraising. So it's a really special spot. Sometimes people go to Ty Watson House for, I call it tune-up. So I need to just adjust meds or struggling too much with constipation. It's hard to get on top of it. We'll admit them for a few weeks if we have the capacity, because it is small, it's 4 beds. And then home palliative care is probably one of our big focuses in town, and I think we do a beautiful job of it. We have a team in home and community with nurses, RNs, we have the healthcare aides, we have a dietitian, we have physio, all the stuff, and we see our patients and support them at home. So we can organize hospital beds, lift chairs, 4 times a day care and support, med administration help, to try and keep people at home, because for most people that's what they want, is they want to be home. Granted, that is often dependent on how much support they have. Do they have family around? Or, are they living on their own? And with some of the elderly patients, like their children are elderly, so they sometimes are quite frail. And that's where Ty Watson House is a huge benefit. And then, as always, if the hospital, if we need to, but we really try hard to keep people out of the hospital. Why don't I just ask, do you guys have questions? Things listed here. So, do I ever give patients a timeline before they pass away? It entirely depends on the patient. I kind of get like a vibe, a sense of the person I'm seeing and their family very quickly upon meeting them. Like, how much do they, and I'll ask, how much do you want to know? Some people are like, I do not want to know how long you think I have, and most people want to know. And with some diseases, cancer, some things I can be pretty accurate. And I always tell people, like, I love nothing more than being proven wrong. I would love if if something happened and you could be here longer, as long as it's good. I don't wish for you to be here and suffering, but I'm confident in my ability to not let someone suffer. So sometimes I can give them a really good idea, but I always preface it that I am wrong like 200% of the time. As awful as that sounds, there was a study done that showed that, so it's pretty bad. If someone has heart failure, COPD, and renal failure, those patients are very up and down. They fall apart and then they bounce back, and those trajectories are often very long, and we see that a lot with our COPD patients, whereas cancer is sometimes a bit easier to predict and have an idea of what's going to happen. When patients are at home or in the hospital or hospice, I often speak to the families, especially as the end is nearing, and explain the things that I look for that give me hints that things are advancing and we're getting close. So we talk about changes in their breathing. We talk about changes in their consciousness. Patients often will suddenly be almost unconscious and not able to talk, and it's like you can't even rouse them. And the brain is preparing them for that actual transition. So they will be almost comatose. And then suddenly they'll wake up and start chatting, and it's like, what was that? And that's normal. So preparing families that is what to expect is really important. And making sure they're aware. I often warn them about a hurrah. Patients usually have like a last hurrah where suddenly they're like playing cards and they're visiting, and even someone with dementia will suddenly remember a whole bunch of stuff. And I say, when that happens, rally the troops, bring everyone in, spend time, because it's usually a big sign that things are about to change and it's not going to last long. And often we see a rapid deterioration after that. It's pretty consistent. It's uncommon that I don't see that happen. And we talk about, looking at the coolness of their extremities, looking at modeling. I often look at earlobes. When someone's ear starts to collapse against their head and their earlobe collapses, I know that their body is really prioritizing its circulation centrally. And we talk about how patients suddenly will look gaunt. It's like all of a sudden there's just no collagen. There's just like nothing left to keep them looking almost vibrant, right? And changes in skin color and tone. So I think preparing people for those things so that they're not shocked or surprised is really, really helpful for families, and not assuming that families know this stuff. Because even if they've been present for someone passing or dying in the past, it may have been traumatic, and so they will block it out. Their brain will protect them by blocking it. So, just reviewing and saying, this is normal, and then I expect to see this, I think is really important for sometimes patients and families. I've definitely had patients where I have explained exactly what the dying process looks like. And obviously it's with their permission, and they're usually quite grateful to know what it looks like. Because Grandma doesn't die at home anymore. Grandma, for a long time, came to the hospital to die in the hospital. So that's really been something we're seeing a change now. So what is hard, what is daunting and difficult dealing with grieving patients and families? All of it. And I think probably some of the most important pieces, especially when it comes, because what you will find is it's not often the patients that are challenging. It often is the families. Some of it is, I think a lot of us can kind of slip that family member's shoes on, and we kind of put ourselves in their position and be like, oh my God, like I can feel what you're going through. So being able to kind of just take a big breath and ground yourself before you interact with those patients, family members, and the patients, but I often find it's family that is the most challenging, and acknowledging that they're losing someone who is the center of their world, and that they may have, their filter may be gone. So they may say things they do not mean. They may behave ways that are completely out of character. And giving them a little bit of grace, which is not easy when you're super busy running around like crazy and you start to sometimes feel attacked by people, in all honesty, and it starts to feel like you're being singled out, and it can actually be a little bit scary and feel very intimidating. So I always try to ground myself, take a couple breaths, and remind myself what this person is experiencing and going through, and recognizing that some of those people, that is how they are. That's their like normal personality baseline, and just acknowledging that as well can be helpful. Being honest, taking your time when answering questions, and if you need to call someone for help and support, you just do it. And there need to be boundaries. People are not allowed to abuse you, whether it's verbal, physical, obviously, but even verbal, right? Like if someone stands too close to you, sorry, that's too close, I'm gonna have to ask you to step back, even though it can be hard to do. So time to give them space, time, recognizing that what is being thrown at you is not actually meant for you. It's a reflection of how they're feeling and what they're going through. But it's not easy, and there will be some that are way harder than others. So yeah. Let me see, what else is on here? Anybody thinking of anything? Has anyone had a challenging situation? Has anyone had a palliative patient that they can reflect on that's been really challenging, and you don't know that you would have done things the same way, or you would want advice of how to do it differently? And I'm kind of putting all of you guys on the spot.
You're right, it's usually the families that are the difficult, like the patients themselves are quite often fine. Patients the families.
Know. And patients know, right? I have only surprised 2 people in my entire career that either their cancer was metastatic or that they're dying. People know, and sometimes they know for months, and they don't say anything to anybody, especially like 80-year-old men. Not to generalize, something about that demographic. They know for a long time, they're super, super sick, and they're just, I think it's that they actually really just want to let things happen. Let life happen as it happens, and they see how sometimes our interventions shorten lives and make lives really difficult. Like, we cause harm sometimes, and I think that's sometimes that really tricky balance of, and it can be hard to have the conversation of when do we start to cut back on the IV antibiotics and IV fluids, which is a really hard one, oxygen. It can be so hard to say no, and for some people, and I think we have created this, that people feel like they're quitting, right? Like, lost a battle. We read that in obituaries. There is no battle. This is just life. These bodies are not meant to be here forever. They are here way longer than they were 100 years ago because of medical intervention, but we have not found a way to keep you alive forever. And there's a disconnect sometimes. So having those conversations, or even just beginning those conversations and mentioning, we do have to be careful with your IV fluids. At some point, your body can't use it because your body's dying. Your legs will start to swell. You'll start to get fluid in your chest, and then you might start coughing and being congested. That is never talked about on TV, right? We see the chest compressions, the intubation, the person walks out of the hospital. We don't talk about the other side of things, and that's the realistic side, in all honesty. So having those honest conversations and being cautious with, the amount of medication sometimes you throw at people. And I'm telling you, patients know. It is, like I said, 2 people that I've shocked. They usually know what's going on, and giving them permission to voice what they want is huge. Sometimes you have to ask family to step out for that. So, and in the hospital, please pull in social work and our spiritual care advisor, because they're fabulous to help bridge some of those conversations that we don't have time for because of the system, in all honesty. So I think that's really important to keep in mind. Yeah. See, is there anything else? And so there is a comment here about, having the conversation with patients and how do you bridge that conversation. I think that, I kind of spoke to it a little bit, but I often approach it with curiosity to see what the family and patients know or what they're feeling. So instead of me telling them what's going on, I will try to ask them to kind of dig deep and see, what do you feel is happening? And approaching with curiosity, and I think that lends itself to when you're dealing with families. Approach them with curiosity rather than having your back against a wall, which is so much easier said than done. Take that with a grain of salt. It takes a lot of practice, and there are days where I'm just I don't have this in me today. So number 1, recognizing when I feel like that, so that I can go outside, take some deep breaths. I'm a big fan of taking off your shoes and putting your feet in the grass, and just calming yourself and recentering before you go in, and acknowledging, okay, I am feeling something that is affecting this relationship with them. Stepping back and then trying to come in with curiosity is important. And trying to be open to their questions, and being confident in saying, I don't know. Be honest. I don't know. I don't know how long you're going to be here. I know I can help you live well with whatever time you have left. That I know. I don't know what this is going to look like, but we'll be here, and we're going to support you, and we have resources and other people that we can pull in to support you and your family as well. That often eases a lot of patients' worries, knowing that there are other people who can support the family, even when they're gone. And that kind of leans towards Ty Watson House. Again, with the hospice, we have a fabulous group of people, so volunteers. We have counselors there to support people. Their family member doesn't even have to be part of, they may not have died on my palliative service, but if you have lost a loved one and you need a little bit of help with your grief, you need some help processing and how to live with this and ride the waves of it, because you don't go through the 5 stages of grief and then you're good to go. It's going to come and go. Everyone does it in different stages. It's not a pattern, and it's like the ocean. It's just waves. It'll be hard, and it'll be a little easier, and harder and easier. So we have counseling through there. We actually have people who come do Reiki and sound bowl therapy and massage, and that can be even for family members. You're a caregiver, go for a massage. So some of the resources we have available in this community in groups. So there's a MAID group starting for family members who feel so often people feel, well, I'm left behind, my loved one's gone. And then we have a men's group for grieving spouses, and there's grief walk and grief journaling. So there's an incredible amount of resources. So if someone dies in the hospital and the family, you'll get to know the families, and you're I'm a little worried about them. You can actually do a referral with their consent. There's a referral form that you can do a referral to Ty Watson House with their consent, and then Moira or someone from there will reach out to them and look at saying, hey, do you want to just come in for a cup of coffee? Come to the house and we'll see what might work and support you best. So I think that's an important resource that is not well promoted in the community, but hugely valuable. And it lends even to healthcare providers. So if ever you're like, I had a horrible traumatic, this death was really upsetting, or something occurred with a patient who passed away, and you need some help supporting it. I know usually there's good support through unions and things like that, but sometimes it's nice to have that local connection. So just know that that's actually also available for all of you, which is really cool. Mm-hmm. Yeah. I was a little bit all over the place, but it's such a big topic. Does anyone have questions about MAID? Whether or not this, to me it's all under the same umbrella. So I don't know if anyone has any questions, if anyone's been involved in a medical assistance in dying.
I wonder if you could speak to like the dying process and the family dynamics, and how, in your experience, you see that being different when MAID is being utilized versus when it's just a natural progressive death.
Yeah. So MAID is one of those things. I did not go into medicine to provide MAID. You know, and I tell patients and families that I didn't go to school for this. This is not at all what I went to school for. I was supportive of it from day one. I did assessments. I only started providing MAID when I moved here because there was such a need and we didn't have a lot of providers. And it is one of those things that until you are part of one and experience it, it's really hard to explain. Many patients request MAID. Like, I have tons of people who request MAID. I've had a 100-year-old request MAID, and I've had a 32-year-old request MAID. And my job is to determine, are they competent, are they being coerced, and just assessing quality of life and what it means to them. And it will be different to everyone in this room. Everyone's opinion of what quality of life is will be different. Families struggle. For the most part, my experience has been that families will support their loved one in whatever they feel is the right thing for them, even though some family members may not actually truly believe that this is okay. And some families, it's really, you know, people can't support them, and that's unfortunate. It's heartbreaking, but it's the reality. And there's nuances to that. But when it comes to when someone requests MAID and they decide, I'm picking a day, I'm ready, there is an incredible shift that happens in the patient. There is a tremendous amount of peace and calm. And my experience has been that if someone has a lot of symptoms and they've decided to proceed with MAID and they've picked a day, some of the symptoms settle down. It's almost like a release. This tension is gone. And I often will tell family members, do you see a shift that just happened there? Did you notice that? And family members will notice it, and I think that's helpful for them. Just to see the confidence and the peace and I've had some people like almost excitement, like, okay, it's time, I'm ready. And it's peaceful. So we use a combination, there's an oral option and an IV option. I think we've only done one oral option patient on the entire island, because you still need an IV. You can't eat for like 8 hours before. There's a lot of more rules and more restrictions, whereas the IV, one of my nurses will come in and start the IV usually about an hour before I arrive to the family's home or to the hospital or to the hospice. And I show up with my medication that I work with a pharmacy to get, and there's a lot of rules and regulations. Like it's meticulous. And I have 4 medications that I provide in succession, and I confirm the patient is still competent and gives consent. And I will tell you, 98% of the time the patients are like, do not ask me again if I consent to receive MAID. I'm ready, like, that's it. And like, people start to get mad at me. And I have had patients get like a little bit belligerent. Stop asking me. I would have changed my mind a long time ago. And it's also nice for the families to see that, right? Like, they're so ready. So it's very peaceful. It's about 10 minutes, the entire thing. They initially go to sleep with midazolam, and I warn people they're going to snore. If they didn't snore before, you're about to hear it, and they usually do. And I remind families, like, they hear you. And I think even when there's no heartbeat, your person is still here. They still hear you. they still know what's going on. Like, I've had enough dogs that have like stood at the patio door staring down the street for no reason, and the patio door was open. And we're like, that dog's never quiet. The dog never goes there. He's staring down the street and you cannot distract him. I'm like, so as you can tell, I'm a very spiritual person, like, and I do believe there's something more. And we see it. So MAID is very peaceful, and a lot of natural deaths are as well. The ones that aren't, I find, tend to be when people have regrets, trauma that's not resolved, or they have fears. Right? And some of this we can address, and that, you know, if we have the time, those are things we can talk about and maybe help them with. And that can improve what their dying process looks like. We can't fix all of it, and those people don't usually request MAID. They request MAID, they don't usually do MAID. Because they're not ready to die. They have stuff they haven't done, whereas a lot of people who request MAID have made a peace with what's going on. They may not be happy about it, but they've made a peace with it. And it's nice for them to have that last little bit of control. For the families, I think it's really weird. A lot of families have a hard time wrapping their mind around the fact that, like, they picked a day. Like, today you've decided. And that's where with Ty Watson House, we're starting a support group, and we're trying to pull in more supports for family members, because it's still very new here, and it's freaking weird. Like, I don't lie about it. It's strange. I never leave a MAID without being a changed person. There's a piece of me that changes every single time. And the day that stops is the day I need to stop doing it. But it's a very peaceful, beautiful passing. Yeah. If you have the opportunity and it's something that you support, it's nice to try to be involved. In the hospital, it's a nice controlled setting as well, so sometimes that's a nice thing. In the communities, like, sometimes patients are drinking scotch first, and like, there's all kinds of stuff. It's very, sometimes, to be honest, it's often a bit of a party atmosphere, which is pretty cool. We celebrate birth, why can we not celebrate death the same way? We're very fearful of it, so hopefully that keeps changing over the next however long this is going to take. Yeah. Anything else? Okay. If there's ever anyone who has questions, is unsure, like, you can always reach out to me or send me an email, like on Island Health, because stuff will come up, you'll be like, shit, what do we do now? So yeah, you can always reach out.